I think we move on now to this very important questions or problems that we normally don't discuss in these kind of hi-fi IOL stuff, and it's a complication. And there is no better person than Dr. GAURAV LUTHRA to talk how he handles complications. It's a very big topic, but he has condensed it to the time slot that we have. So, GAURAV, please, we are looking forward.
A very good afternoon, everyone, and thank you so much, sir, for highlighting my topic. And after that wonderful talk by Dr. Tityal, sir, I'll try to just share a few examples of what are the common complications we can face during premium cataract surgery. And of course, every surgery is premium today, as you know, Dr. Vasavada and Dr. Tityal highlighted. Every patient is important and every eye is important, and for the patient, every surgery is a premium surgery. So you can't frankly differentiate, but then the tolerance of some of the newer technology surgeries is obviously less than the other surgeries. So when you are dealing with patients with high expectations for visual outcomes and for the choice of procedures that you're offering, it becomes imperative to make sure that if you end up in peculiar situations. So this was one of those surgeries, and I remember when a particular multifocal IOL was recently introduced. It was a trifocal lens, and I was quite excited, and this was just the second or third lens I was going to implant. And I thought, you know, very predictable surgery and everything goes smoothly. So we were doing a femto-assisted surgery with LRIs and neutralizing some of the astigmatism, and everything seemed to have gone really well. And I was going to inject the lens and get it over with. And it was probably the second or third lens I was implanting that day itself, because it was just introduced then. And it looked so good, and this small tug there, and suddenly I felt that something funny is happening. It's not really, you know, and it wasn't like a sudden injection. It wasn't like a, you know, shooter lens getting shot inside the eye or anything like that. And I can take you back for you to see it again. You know, as I inject the lens, it goes in fairly smooth, almost all the way, and that's the last part where I've just kind of pushed it through the wound-assisted injection, and it kind of goes a little bit too beyond. So I try to bring it back. It finds itself difficult to come back. I finally realize that something is not right, and it's probably trying to go out of the equator of the bag. And then I try to inspect. The lens is still unfolding, and this is the crucial time when you can actually try to reposition it if you've created a complication. So such situations you need to be alert. You need to minimize further damage, and it can still be retrieved. And so once I pulled the lens to the side and assessed the damage, I could see a break in the posterior capsule in the periphery. There was a equatorial break. So with these hydrophobic lenses, especially if you are doing wound-assisted injections, one has to be careful not to be pointing the lens towards the PC. It might happen only 1 in 100 times, but it can go through the equator, it can go through the bag, it can even go and cause a hyphema from the root of the iris. Especially if you're having a very tight injection, please don't proceed. You can always come back, reload the lens again, and then go back. I was here able to rotate the lens out of that way and position the haptics in such a way that you know, it still remained very well centered. If it was even worse than this, all I had option left was to do an anterior capture on the rhexis, because with the femtorhexis you can still do that. But these lenses are not ideal for doing that, so I would avoid doing that unless that was my last resort. So when you have a disruption of the PC, you will obviously not leave any of these lenses, especially toric lenses or multifocal lenses, if your PC support is totally inadequate. But if it is a small break which is controlled and no vitreous presentation, you can still get away if you have already reached the end of your surgery, or you can do a reverse optic capture, and that can also work in some of these situations. And I think Dr. Vasavada's group has done extremely good work with reverse optic capture, and Shell has shown us some excellent videos of how to do that. And only problem is that some of these lenses are posterior angulated, and it may be difficult to capture unless your rhexis is perfect. Going on, this was another patient who presented to us. Fellow eye had a perfect 6.6 N6 done with a multifocal lens. The second eye, there was a pupil which was totally drawn to one side. a patient had been to many places and wanted a surgery for, with a multifocal implant, and had significant astigmatism as well, and was not keen to go for a monofocal toric as much as we would want. So multiple challenges is here. And then the surgery became even more complex as it went along. We had planned to do, we got a customized trifocal toric designed for this patient, and went ahead with hoping to do good surgery. So let me just take you back. Everything is going well so far till we reach this point where the rhexis starts trying to run away, and this is the same area where there was a small pathology in the iris, in the cornea. So there seemed to have been trauma during childhood. And even the capsule, I realized here, was fibrosed in a peculiar way, so that when I was trying to do the Brand-Little's maneuver to bring this rhexis in, it was still trying to run away. And I repeatedly tried to use viscoelastic to get better visibility. The pupil was small, and it was still not ready to come back. So I then had to resort to further measures. Of course, refilling with viscoelastic, went from the opposite side, hoping that I'll be able to do that. It didn't work. Still wanted to run away even further. So now it was so far that it was not visible. So I went with a wide-tipped manipulator. So it's critical to have your rhexis intact if you're planning to do any of the lenses, toric lens or a multifocal lens. And frankly, at this time, the only thing going through my mind was that if I don't get my rhexis back, everything else that I've planned for this patient will go for a 6. I won't be able to put in a multifocal lens. I won't be able to correct the astigmatism. So it was imperative. And finally, I did eventually use the Brand-Little maneuvers in 4 different steps, and did manage to bring this back in some way. So frankly, that was one part of it. And then, of course, removing the cataract was fairly straightforward. I'm sorry for the poor contrast for some reason. I can appreciate that it's not great. I should have increased the brightness for the recording. All the same, when once I was able to remove the cortex completely and refilled with viscoelastic, I now suddenly felt my rhexis had extended finally, and it was going there, and it was going right under. And I was scared for a moment that this is going to extend, and I won't be again able to complete it. Yet go back and check with a wide-tipped spatula, and I found that no, it was actually intact. So I breathed a sigh of relief, went ahead with the lens implantation, and that went smoothly. Positioned the toric lens, did a sphincterotomy because I knew that this pupil cannot be centered. It's going to go back straight to the corner of the eye. Did some relaxing sphincterotomies there, 2 small ones, calibrated ones, checked for the centration of the lens, both for the optic as well as for the toricity. Went back, and now I have to reconstruct the pupil because the lens edge is visible. So frankly, when you're doing these premium surgeries, you have to be prepared for almost every eventuality. There's little room for error, and you have to be a perfectionist. Your rhexis has to be always perfect, your incision has to be perfect, your planning has to be great, your marking has to be good, and you cannot be in a rush. As Dr. Vasavada repeatedly said, you cannot be rushing through these surgeries. You have to plan them, and yet you can't be slow enough that you can compromise the surgery. A single pass 4-throw pupiloplasty here will make this pupil smaller, and that will make our pupils look much better. And this patient, frankly, at the end of it, looks much better than what he was preoperatively. And I was able to have a clear visual axis and toricity, and then was able to complete the surgery. So this is how the patient looked first day post-op, much better, well-centered pupil. This was, of course, dilated, so it's looking a little bigger, but it was fairly well-centered. Now, this patient was planned for an Eyhance lens, and so that's not a very premium lens in that regard, that it's not a multifocal or something. Yet, patient had a fellow eye with also an Eyhance, and there was a small surge, as you will see over here, as I was doing my capsular. Let me just take you back, and if you just notice this area, I'll just catch the capsule for a moment, and I break the PC. And then I have to, of course, go and retrieve it. So if you have a small PC break, it's best not to continue with the surgery. You can always go back and convert that into a small continuous rhexis. So here I'm using these special forceps which I've myself been responsible for designing, where you can see through the micro rhexis forceps, so you can see under it. If you'll notice that I was trying to use my older forceps before this, which kind of closes, so you can't look through it, so it's very difficult to visualize where you are going. And then I switch to the newer design, which is what I'm using now, and you can actually see through it and see under it. and you can have full visualization, and you can just convert this into a rexus. Now once you've done that, it's a small 1 or 2 millimeter rexus, but now you can breathe easy. You can go and complete your cortex removal, you can remove everything. If I had not done this, gradually over time this break would have enlarged, and then I would have gone and done a vitrectomy, and then I would have changed my design for the lens, and everything would have gone for a 6. So with that I could place my preferred lens. Sir, I'll just show one last video and then I'll be done. So this was a patient where a toric IL was planned. He's a one-eyed patient, hard brown cataract with subluxation. So the lens was having a lot of phacodonesis, and post-vitrectomized eye, had delayed his surgery for almost 7-8 years because the fellow eye was lost to a retina surgery.
I think, Gaurav, you may continue talking, but let your laptop be closed, because with the time I'm pressed for the... So what did you do then? Tell us, describe what you did.
It's very complex, so I won't be able to tell actually. Sir.
Yeah, but so, no. Oh, really? No, give us some pulse. No, I want you to give because your pulse will make a lot of difference to the people. So please tell us what was the situation, clinical, and whatever you can without the video.
So essentially it was hard brown cataract, subluxated. I managed the rexus fairly easy with capsular hooks and everything. Removed the cataract, and then there was, because it's a vitrectomized eye, so there was an adherent dense plaque which was all over, and the bag was obviously dehiscent. So removing it was almost impossible, because as you try to scrape it, it tends to come off. So I was going to showcase a jet wash, which I used to kind of, wash them away very fast with a special instrument. And then a broken rexus, so a toric lens would have been, was planned. So all those challenges. Basically.
So what did you do at the end? Did you do the toric?
No, I abandoned the toric in the end, because it was a, it was a bag which was very fragile.
And could you water jet the plaques?
I could clear everything, including, kind
This is a very useful trick. Safe. You can't go wrong. Maybe it will not work sometimes, but it's worth trying. So what Gaurav brought out is a very important surgical thing you must keep in mind, that with a forceful jet, it is possible to kind of peel off these opacities of the capsule. May not work every time, but it's something you must keep trying, and if you master it as he has, and I remember seeing this peeling off by water jet once in one of the meetings, it's wonderful.